Good afternoon. My name is Dr. Clement Muka. I'll be continuing actually with drug-resistant TB. Today, I want to look at the baseline tests that we need to do before we actually initiate a patient on drug-resistant TB treatment. So, what one should remember is that how did we diagnose drug-resistant TB? We used an area or a spot in the Mycobacterium tuberculosis genome. That spot is given a special name. We call it the RPOB gene. The presence of that spot, it actually says there is TB because it's a part of the cell wall of Mycobacterium tuberculosis. And this spot is susceptible or sensitive to rifampicin. And this is what is known as the RPOB gene. So if it is there, there is TB. And if it is susceptible, it will tell us whether it is susceptible to TB treatment, to rifampicin, that is rifampicin in particular, is sensitive to rifampicin. And if it is sensitive to rifampicin, then we know that we're dealing with DSTB, we're dealing with drug-sensitive TB. But if it is insensitive to rifampicin, or resistant to rifampicin, then we know that we're dealing with drug-resistant TB. And this is, they call it RR, rifampicin-resistant TB. And we have got all the other types falling under this one topic. You will remember, we said there's mono-resistance if one antituberculous drug is being resisted. Doesn't matter which one. Mono-resistance. If we have two or more being resisted and other than INH and rifampicin, we call that polyresistance. And then we go on. If we have rifampicin still is being resisted, but we have a fluoroquinolone that is also resisted. A fluoroquinolone that we're thinking of levofloxacin, because that's the one that we're using. Though the most potent one is the moxifloxacin. So what we're saying, therefore, if one of these is being resisted, there is another one called ofloxacin. If one of these is being resisted, in addition to the rifampicin that is actually resisted, then we call this pre-XDR. If we have the rifampicin resistance and we have the fluoroquinolone resistance, doesn't matter which one, levofloxacin, ofloxacin, or moxifloxacin, doesn't matter, doesn't really matter. If it is being resisted, and then in addition to that, you've got bedaquiline that is being resisted, or linezolid that's being resisted, none of those group A drugs, then we have XDR. And we said, this is very difficult to treat. But now we need to start treating. To start treating, we know the drugs that we are going to use. We're going to use bedaquiline. Bedaquiline has got this one characteristic feature. It prolongs a QT interval. QT interval is something that you find in an ECG. So one of the baseline tests that we have to do is an ECG to check how is the the QT interval before treatment, before giving bedaquiline, before giving levofloxacin, before giving clofazimine. Those, they prolong the QT interval, and we're worried. And that is why it is so essential that we weed out all those drugs which are prolonging the QT interval before initiation of therapy. We need to weed them out. And we said, we used as a very good example, that is tretinoin. Tretinoin can be used for, for depression. It's an antidepressant. Even if you're using it for antidepressant, we shall have to use a different antidepressant. There are so many other antidepressants. We have to use others instead of this one, because this one has got this property of prolonging the QT interval. And this is a property that we don't want now, because we're going to use bedaquiline. We're forced to use bedaquiline because bedaquiline is very good in wiping out drug-resistant TB. Clofazimine is very good. Levofloxacin is very good in wiping out drug. So we have to use these, but we need to weed out all the others which are prolonging the QT interval. Most importantly, we need to check the electrolytes. Oh, that's because there are electrolytes which, when not checked, will prolong the QT interval. And this will be in addition to the bedaquiline that prolongs the QT interval. We need to know, why are we worried about prolongation of a QT interval? What's the fuss? Why are we worried about it? We're worried about it because it causes these polymorphic ventricular arrhythmias. Who wants an arrhythmia? I have a patient here in front of me. The patient has got a stable heartbeat and there's no problem. And then now I give my drug. I say, this is a good drug, bedaquiline. This is a good drug, levofloxacin. This is a good drug, clofazimine. Oh, no. And then the patient, after taking my tablet, the patient starts having problems with the heartbeat. Actually, what we should understand is that no one is supposed to know that, oh, my heart is now beating, it starts beating. No. It's an automatic process that you know what? Once you are aware that, hey, my heart there's something wrong, it doesn't matter what. Right now, I don't feel anything, but if I were to be conscious of the fact that my heart is beating hard, my heart is doing this, then there's something wrong. And that is why we need to check the electrolytes. Which electrolytes are we worried about? We're worried about magnesium. We're worried about calcium. We're worried about potassium. Those are the three which prolong a QT interval whenever they are low. Low levels of these drugs. If we have a hypomagnesemia, low magnesium level in the blood, and we have hypocalcemia, we have low levels of calcium in the blood, we have low levels of potassium, we call that hypokalemia. So if we have a hypomagnesemia, we have a hypocalcemia, we have a hypokalemia, we are in a problematic situation. We need to correct this. We need to correct. We will go to an extent of keeping magnesium, magnesium oxide, MagSalve, to try and up the magnesium. Calcium, we do a lot of things, promote calcium absorption and all that in the gut, we use vitamin D, something like that, to try and make sure. We need to correct these. With potassium, KCl we can give KCl, for instance, slow K, to try and make sure that the potassium is at the correct level. We don't want a hypokalemia. We don't want a hypocalcemia. We don't want a hypomagnesemia, because all these three, they prolong a QT interval. And so, if a patient has got all these three, or any one of these three, then that patient is not a good candidate for bedaquiline. Is not a good candidate for levofloxacin. Is not a good candidate for clofasamine. Those are prolongers of a QT interval, and we don't want that. We don't want that. Polymorphic ventricular arrhythmias, which are caused by prolongation of a QT interval, is something we don't want, because, it can give rise, there's an abnormality known as Torsades de Pointes, where these patients, they're lethal, They're lethal. They actually kill the patient. We don't want that. So, it is crucially important to check the electrolytes. And when you are talking of electrolytes, you are thinking of magnesium, you're thinking of calcium, you're thinking of potassium. And that's very, very important. And, if you do that, you are a safe healthcare worker. Because you'll make sure that your patient does well. Right? You are not going to get complaints from a patient saying, "Doctor, after taking this tablet of yours, I don't know what happens to my heart. I don't know what happens to my heart. It beats fast and all." No, we can't have that. We can't have that. And the patient has got a right to ask, "Doctor, did you check my potassium? Doctor, did you check my magnesium? Doctor, did you check my calcium?" The patient has got a right to ask that, and to make sure that you safeguard, your health as a patient, right? This is something that we need to worry about whenever we are to initiate these patients. And there's yet another, another issue that we need to talk about. The TB, whether we have TB or not, or whether we have TB that is advanced, it is important. It is important to find out, remember what we think drug-resistant TB, but now, is it advanced? It's very important. How will we know that it is advanced or it is not advanced? You have to do a chest X-ray. So, if you are in a hospital situation that's first class, our government hospitals, they've got all X-rays, so we don't have a problem. Well, if you are in private practice, I don't know if you have, but you need to do a chest X-ray. And then, what are you worried about with the chest X-ray? I need to check whether I have cavitations, both sides, bilateral cavitary disease. I need to establish that, because that's a determining factor as to say, this is an advanced TB. This is an advanced TB. That's very important. An advanced TB. Normally, when the CD4 count of the patient is less than 200, and you get these bilateral cavitary disease, and that's important to sort of know that this is what I'm dealing with at this present time, right? This is what I have in mind, and this is very, very, very important. And we are not going to forget that our treatment has got to be bedaquiline, pretorminate, levofloxacin, and linozolid. In fact, and that will dictate terms. That will say, I need to know what my HB is. HB has got to be all the time greater than 8 grams per DL. All the time. That enables you to use BPAL-L, which is what I've just said. Bedaquiline, pretorminate, levofloxacin, and linozolid. And that's crucially important. That if it happens that you have extrapulmonary TB, and this extrapulmonary TB is severe, and when we say it is severe, if you have a CNS disease like meningitis, that's severe enough. That is severe enough. So you have a TB that is extrapulmonary. We are in a problematic situation, because now it changes everything that I've been sticking to. It changes everything. Instead of using BPAL-L, then I'm going to use now what is known as a long regimen, an individualized long regimen, because BPAL-L is a short regimen. And there is a time when we use just BPAL, not BPAL-L. If there's fluoroquinolone resistance, if, for instance, you find that you get a result from the lab that says ofloxacin has been, has been resisted, or it's being resisted, you have levofloxacin that's being resisted, you have moxifloxacin that's being resisted. You know now that you can't use BPAL-L. You're going to use BPAL itself because the levofloxacin is out. It's a fluoroquinolone. So that fluoroquinolone cannot be used now. You're going to use BPAL. What's your BPAL? Your BPAL is your bedaquiline, your pretorminate, your linozolid. And that's what you're going to use. That's BPAL, not BPAL-L. Now, what else? What else? Is it only, I said extrapulmonary TB. I need to know all types of extrapulmonary TB so that I should know. If you miss this one, for instance, say you don't see that you have got extrapulmonary, you've got a patient has got meningitis, you don't see that, and you continue to BPAL-L, that patient is going nowhere. That patient is bound to fail. Bound to fail. There's no way, because you are treating severe extrapulmonary TB with using the short regimen. That is sad for the patient. So the second one, you've got your meningitis. Meningitis is a very good example of an extrapulmonary TB. You have TB pericarditis. The pericardium is that's the covering of the heart. If you have got inflammation of that cover, we call it pericarditis. So if now you've got TB pericarditis, that's a severe TB, severe extrapulmonary TB. And that's good to know, because this patient is going for individualized, long regimen instead of a short regimen like the BPAL-L. And that's important to know. So that's TB pericarditis, TB abdomen, TB abdomen. You see this patient with a distended abdomen because of the peritonitis that is, oozing fluids from the peritonitis and all that. And then the patient has got we have had a patient like that. Oh, we were busy with BPAL-L. I mean, that was useless, really. That was useless. The patient should have been sent to, we've got a place that treats these patients. We call it CISO Hospital. It just does drug-resistant TB. It's a specialized institution. Oh, it's a center of excellence. Patient who's like that should be sent there. And patients should be discussed with the provincial clinical advisory council or committee. Provincial, we've got a provincial one, we've got a national one. We discuss patients like that. You know, we do have sometimes patients who test positive for, RR-TB. RR-TB. RR is rifampicin-resistant TB. And yet these patients are pregnant. We are allowed to initiate these patients without sending them over, but we need to discuss them with the provincial clinical committee, the clinical advisory committee, or we discuss this with national if we can't find the provincial ones. We discuss it. The thing is, as an isolated case, because this patient is pregnant, this patient is also testing positive for RR, for rifampicin-resistant TB, right? What else? Are there any other extrapulmonary TBs? Yes, osteoarticular. Osteoarticular, it's the bone TB. Bone TB. Oh, I once had a nasty experience. I see a grandmother pushing a wheelchair of a grandson. Grandson is 18 years of age with osteoarticular TB. Oh, osteoarticular TB. So the boy can't walk. I mean, at 18 he can't walk because he's got osteoarticular. It's right here, a spine TB. Spine TB, So osteoarticular is severe extrapulmonary. And you can get this with sensitive TB. You can get this with DR-TB, that is drug-resistant TB, which is the one we're talking about today, right? So first of all, you must get a GeneXpect result that says, yes, positive for RR, rifampicin resistance. Then you start locating your extrapulmonary TB, your severe extrapulmonary. If it's in the bone, then you say it's osteoarticular, right? These are the extrapulmonary TB. You know that if it's extrapulmonary TB and the patient is testing positive for RR, you know that you're dealing with an individualized long regimen. And this is so important. If you get the patient to be okay, you don't have to do anything at a primary health care level. What I mean in terms of actually managing, well, you can manage the patient, but what these committees must know, the National Clinical Advisory Committee must know, or the provincial must know, so that, well, in our case, we are lucky we've got CISO Hospital, where it's a center of excellence, where all these patients are being treated. They go to an extent. For instance, some of these drugs, even the very drugs, second-line drugs, the first-line drugs are the what? the rifampicin, iron H, pyrazinamide, and ethambutol. That's the first line. Second line are these drugs that we're talking about now, the bedaquilins and the pretomanids and the linozolid, the levofloxacin, and all that. That's second line, right? So if these second line drugs are being resisted, no, it's not your baby. It must go to these committees, high committees. It must go to the provisional clinical advisory committee, because those are the people who will advise you. Those are the people who will take a decision as what needs to be done right now. They go to an extent of, the center of excellence, go to an extent of using drugs that we don't know at all, that we don't use at all. Like Delamine, those are drugs that we don't actually use at our primary health care centers. We don't use those, but they've got that chance. They've got I want to say thank you very much for listening to me, and I would like to go on with this. If there are any other things to wrap this thing up, the drug-resistant TB, I'd like to do it sometime. For now, bye-bye, and let's do it.